that all of you all have taken time out at night time away from all other duties. It is my proud privilege to introduce Dr. Watts. I will introduce him only briefly because I don't want to take him away from the rich vein of experience he's going to share. Dr. Watts is a neurologist practicing in Udaipur who has trained in PGI Chandigarh and further on trained with Dr. Sudhir Kothari in Pune and has a center of excellence of his own in Udaipur. We have as a discussant Dr. Rajiv. Dr. Rajiv is a senior ENT surgeon who was a professor in academics until quite recently and is now carrying out a dedicated otology practice in Bangalore. So without standing in the way, I want to introduce Dr. Watts. I want to invite Dr. Watts to commence his presentation on an interesting variant of BPPV. Dr. Watts, the floor is yours.
Yeah.
So, I think you would have, yeah, we can see your screen.
Let me go to the presentation mode. So this is me. I'll first focus on this figure which I have made here. We are going to discuss about the apogeotropic variant of the posterior semicircular canal BPPV. There are three parts of the posterior semicircular canal. This is the diagram which I am discussing here. This is the short arm of the posterior semicircular canal. This is the long arm of the posterior semicircular canal. The typical BPPV is because of photoconal debris in this long arm near the juxtacopular position. And this is the non-ampullary arm of the posterior semicircular canal. And if a photoconal debris detaches from the utricular macula, which I have shown in the red here as a globule, and it becomes impacted in the non-ampullary arm of the posterior semicircular canal, it leads to the apogeotropic variant of the posterior semicircular canal BPPV, which we will be discussing today. So naturally, if you will see this diagram, to remain here, there has to be a secondary pathology, that is a partial canal jam, which could be physiological because of a large photoconal clot, or anatomical because of the narrowing of the tract near the cross commune, or both. So a partial canal jam is almost invariably present in patients who have apogeotropic variant of the posterior semicircular canal BPPV. So what does the apogeotropic implies? So when we do the positional test, the Dix-Hallpike test or the enhanced straight head hanging test, the quick component of the nystagmus beats away from the earth. So this is the animation which I am showing here. This is here the diagram, slow and quick. Again, slow and quick. So this is the apogeotropic variant of the posterior semicircular canal BPPV because the quick component of the position of the nystagmus beats away from the earth. So this is an important diagram from the Bronstein's article. This is about the right-sided canals. The upper three are showing the excitatory projections from the anterior, posterior, and horizontal canals, while the lower panel, the lower row is showing the inhibitory projections from the anterior, posterior, and horizontal canals respectively. So one important thing is that there are a yoke pair of muscles which are either excited or inhibited during a particular head movement. This is a disruptive head movement, and every disruptive head movement in any of the three planes, I mean to say yaw, pitch, or roll, there has to be a corrective movement of the eye so that the fixation is not hampered. As we can see that if we reverse this, that is we are now seeing in the left upper row, leftmost, the inhibitory projections, excitatory projections of the left posterior anterior semicircular canal are to the right inferior oblique and left superior rectus, and so also the inhibitory projections of the right posterior semicircular canal are to the same pair of the muscles, right inferior oblique and so the left superior rectus. So when we'll come to discussion a few slides later on, we'll know why this is important. So this is again a very important diagram drawn from this. The right posterior semicircular canal, the excitatory projections are to the right superior oblique and left inferior oblique. This causes a slow phase vestibulo-ocular reflex, which is downbeating and left torsional. The positional nystagmus, which is a fast phase VOR, is therefore upbeating and right torsional. We are showing about only right-sided the canals here. The inhibitory projections of the right posterior semicircular canal are to the right inferior oblique and left superior rectus. And because of a slow phase VOR, which is upbeating and right torsional, the positional nystagmus is downbeating and left torsional. So the inhibitory projection, this is the apogeotropic variant where the torsional component is away from the involved air, that is towards the healthy ear. The excitatory projections of the right anterior semicircular canal are to the right superior oblique, superior rectus, and left inferior oblique, and the positional nystagmus is downbeating and right torsional. The inhibitory projections of the right anterior semicircular canal are to the right inferior rectus and left superior oblique. And so, if at all there has to be a variant of this canal, that is the non-ampullary variant canalolithiasis of the anterior semicircular canal, that it has to be a upbeating and contratorsional nystagmus. But unfortunately, this variant does not exist. So I'm removing it from the hair. Right horizontal semicircular canal, the excitatory projections are to the right medial rectus and left lateral rectus. The slow phase VOR during the lateral head roll to right is therefore apogeotropic, and the geotropic nystagmus we see during the right lateral head roll is because of a slow fast phase VOR, that is the positional nystagmus. Likewise, the inhibitory projections of the right horizontal semicircular canal are to the right lateral rectus and left medial rectus. The slow phase VOR during the left lateral head roll is left, that is geotropic in the right lateral head roll, and therefore the fast phase VOR, which is a positional nystagmus, is apogeotropic. So this is the Yavar's law. Excitatory projections, that is ampulofugal in vertical canals and ampulopetal in horizontal canal. The inhibitory projections are ampulopetal in the vertical canals and ampulofugal in the horizontal canal. This is a chart which every budding neurootologist should keep in his or her consultation room to know the mechanism, because without knowing them and not visualizing them in 3D, you cannot treat these patients very successfully. So with this, the posterior semicircular canal subtypes, the 6 types I know is the posterior long ampullary arm semicircular canalolithiasis. This is the typical variant which we mostly see. The second is the posterior non-ampullary arm semicircular canalolithiasis, that is which we are going to discuss today, that leads to apogeotropic variant of the posterior semicircular canal BPPV. The third is posterior semicircular cupulolithiasis, that is the gravisceptive heavy cupula due to cupulolithiasis. This is the short arm posterior semicircular canalolithiasis. This is the periampullary canal side posterior semicircular canalolithiasis with partial canal jam. These 4 and 5 variants have been described recently in past 5 years by the Darius Coco from the Argentina. The last variant is posterior long ampullary arm semicircular canalolithiasis with co-occurring opulolithiasis. This is one patient I have recently found. Unfortunately, because of some technical reason, its submitted paper was rejected. So the BPPV subtypes in 12 studies, which I have tabulated here, the Latest one from the Califano 2021 shows that apogeotropic posterior semicircular canal BPPV is around 6 times more common than anterior semicircular canal BPPV. Unfortunately, apogeotropic variant of the posterior semicircular canal BPPV does not find a place in the international classification of the vestibular disorders of the Barani Society. But it doesn't solve our problem as a clinicians. We see more apogeotropic variants, much more than the anterior canal BPPV variants. The high incidence of 21.2 shown in the Jackson et al. You can see in 2007 could be that many of the cases of apogeotropic posterior semicircular canal BPPV were included in this mistakenly. So outline of my talk is long ampullary arm posterior semicircular canalolithiasis. Why I am telling and elaborating here will become clear as we progress through this slide. Non-ampullary arm posterior semicircular canalolithiasis, that is the apogeotropic variant. The epigeotropic posterior canal BPPV symptoms, diagnosis, management with repositioning maneuvers and physical therapy. The suggested readings and finally the future directions. So the case number 1, this is a 38-year-old female patient. She came to me on 30th January with history of positionally triggered dizzy spells. The right distal pike shows a upbeating, torsional, typical crescendo decrescendo nystagmus. So this is a clear-cut case of right posterior semicircular canal BPPV, which I treated with the right apply maneuver. Here I am showing step 1 for 1 minute, step 2, and step 3. She was again called for positional retest a day later. The verifying right distal pike test post apply maneuver did not elicit any nystagmus and the patient was free of vertigo. So why I have shown this video here, it's a story and this has become a history. This patient was seen by me 7 days earlier on 23rd of the January 2020. So I did a Dix Halpike test. Now see this nystagmus. This nystagmus is slow crescendo decrescendo. This is called a semiparoxysmal nystagmus. In the right Dix Halpike, the torsional component is towards the left. And it is a persistent nystagmus. That is, it lasted for more than a minute. I kept her in this position for around 2 minutes, and it was unfatiguing. So it was a persistent downbeating left torsional nystagmus, apogeotropic, because the quick component is beating away from the ground towards the away from the lower pole of the from the upper pole of the eyes, and the torsional component, the upper poles of the eyes are beating towards her left. So as was known to me at that time, I treated her with, I'm taking the next slide. You can just fast forward it here. So it is still present after 2 minutes. 2 minutes and 8 seconds. So then she was uprighted. So what happened between 23rd to 29th January? We treated this patient as left anterior semicircular canal BPPV with reverse apply maneuvers daily 5 cycles for 7 days. The reverse apply maneuver means because we kept a diagnosis of left anterior semicircular canal BPPV, we will start the apply maneuver from the right side. So did she really suffer from left anterior semicircular canal BPPV and was successfully treated with reverse apply maneuvers over 7 days only to develop right posterior semicircular canal BPPV on day 8? So this is our first case of apogeotropic posterior semicircular canal BPPV, which we reported in 2020. And this phenomenon occurred around 10 years back. It was reported in 2012 and 2015 by Paolo Venucci from the Italy. And that's why they came to this conclusion. So this was not a left anterior semicircular canal BPPV. It was apogeotropic right posterior semicircular canal BPPV from the outset. And you can see that the nystagmus which was seen in the after conversion was a typical crescendo decrescendo nystagmus which was upbeating and right dorsal, and the nystagmus which was seen initially on the 23rd January was a slow nystagmus, not typically crescendo decrescendo. In fact, this is similar paroxysmal slow crescendo decrescendo nystagmus, and it was persistent. So the inhibitory projections of the right posterior semicircular canal and the right inhibitory projections of the right posterior semicircular canal and excitatory projections of the left anterior semicircular canal are to the right inferior oblique and left superior rectus. So the slow phase VOR, which generates nystagmus, is upbeating and right torsional. The positional nystagmus, which is a fast phase VOR or a reflexive saccade, is therefore downbeating and left torsional, whether it is right apogeotropic posterior semicircular canal BPPV or left anterior semicircular canal BPPV. So this is a real reason why the two disorders sometimes mimic each other. So the clinical symptoms and signs in apogeotropic posterior semicircular canal BPPV positionally triggered disease spells. A continuous non-positional disequilibrium is the hallmark of the patients with posterior semicircular canal BPPV apogeotropic variant. So these patients are much more dizzy while upright, while walking. So than the other variants of the BPPV, except the short arm variant, where they too are also have this phenomenon. The Dick-Salpike test to the either side and the enhanced health hanging test may elicit downbeating and dorsal positional nystagmus. The downbeating nystagmus is often slow crescendo decrescendo, which is called semi-paroxysmal, and often it lasts for more than 1 minute. The torsional component, which is often little, direct to the non-involved side. So what is the basis of clinical symptoms and signs apogeotropic posterior semicircular canal BPPV? Why do all provoking positions elicit downbeat nystagmus? In every provocating position, the non-ambulatory arm of the posterior semicircular canal takes on a downward slope vertical enough to move the debris in the ampulopetal direction. The second question is why there is no or short latency? Because the debris is not in the juxtacopular location of the ampulla. As long as the otoconal clot moves within the larger portion of the canal, that is the ampulla, it does not have any effect on the cupula. When the debris enters the actual canal, a transcupular pressure is generated, which determines the cupular displacement and nystagmus onset. So here the otoconal debris is already in the canal, and so they have a very short latency or no latency at all. Semi-paroxysmal nystagmus, slow crescendo decrescendo. The otoconal clot in the non-ampullary arm of the posterior semicircular canal has a slower movement rate compared to that in the typical variant, because the canal tract in the former is narrower and shorter, resulting in the friction with the canal walls that slows it down. Long duration of apogeotropic nystagmus, that is the downbeating contratorsional nystagmus, is because the otoconal clot remains partially trapped in the non-ampullary arm of the canal, so that there is no reflex of endolymph and the later keep on pressing the receptors. Ampullary crest comes back to the resting position slower than normally happens. So these are the basis of signs and symptoms, and these are all in the paper by Venucci of 2015. So repositioning maneuvers in apogeotropic posterior semicircular canal BPPV. The demi-surmount maneuver, number 1. The number 2 is the quick liberatory rotation maneuver. The number 3 is the 45 degrees forced prolonged positioning, FPP. So the demi-cement maneuver, here it is shown for the right-sided apogeotropic variant. Here the otoconal clot you can see in the non-ampullary arm of the right posterior semicircular canal, with the head turned 45 degrees. to the non-involved side, the patient is briskly brought to the contralateral, that is non-involved lateral recumbent position, and possibly there is a partial canal jam here. The inertial forces which are generated during this severe acceleration deceleration, they breaks the otoconal clot, and now this is the particles are small enough to encounter this jam. So this is one of the maneuvers, and I am showing a part of this here. Maneuver for the right apogeotropic process in circular canal BPP. Because the apogeotropic variant of Botrytis semicircular canal BPPV is often associated with a partial canal jam near the crus commune, so we have to use the maneuvers which use the inertial forces to dislodge the otoconal clot from the partially jammed area of the canal. So this is in the short sitting. This is the patient of right posterior semicircular canal BPPV. Apogeotropic variant due to canal proliferations in the non-apogeotropic arm of the right posterior semicircular canal. In the sitting position, the short sitting position, the head is yawned 45 degree to her non-involved left side, and then briskly she is being taken to the left lateral recumbent position like this. Should be maintained in this position for around 3 minutes. 3 minutes I am counting by seeing the clock here. 3 minutes is a arbitrary, because the first thing is important. We have given the inertial force. Now, with the virtue of the inertial force, we are waiting that it becomes dislodged, and then it gravitates, either falls back towards the periampulate region, converting into the typical variant, or it goes into the utricle of the right posterior semicircular canal, which will lead to cure. So it is called damaged stemon because only half of the stemon is being back. The original stemon that was described by stemon for posterior semicircular canal BPPV takes the patient through 180 degree sweep. And now we are taking only to the 90 degree sweep. So this is damage and well. So I am just fast. On. It's going to finish now in less than a minute. I do around 5 damage cement maneuver in one session of treatment, and I review the patient for positional tests around 1 to 4 hours later. Now I am uprighting her. इस हाथ से उठाने की अपने आप को कोशिश करना, मैं तो सिर्फ गर्दन पकड़ के रख रहा हूँ, ठीक है, 1 2 3 stop. So I have uprighted her with she has uprighted her, and I have just maintained the neck position. So what happens? The next is the quick liberatory maneuver. Here we take the patient. This is, you just see the rightmost row. We take the patient briskly to the right dix halpi position, that is the side which is involved. So the position 1, the otoconal clot which is jammed here, freeze of the jam, it moves towards the periampulate region, and then it comes to the lowermost region of the posterior semicircular canal during the rapid positioning. In the rapid positioning, it moves towards the common crus. The otoconal, either in the position 1 or position 2, gets fragmented, and so finally it becomes so small that during the nose down position to the opposite side, it gets repositioned into the utricle. I prefer this case more because there are 2 points during the position 1 and the rapid transitioning that the rapid deceleration is being done, so that there are chances of this otoconal clot to fragment and get dislodged from the jammed position of the canal. So this is, I am showing here how I did in this patient. It is with this force I have taken him to the inward side. We maintain this position for around 2 minutes. I'll fast forward this video. तेजी से 1 सेकंड के अंदर फॉरवर्ड लेके नाक में से करते हैं तो now after 2 minutes the transitioning from position 1 to position 2 should be done in less than 1 second. So after 2 minutes I am again fast forwarding it. We'll upright this position again quickly. अब दूसरा लेफ्ट वाला ये वाला हाथ छोड़ो नीचे का और जब मैं 1 2 3 बोलूं तो तेजी से उठ जाए 1 2 और 2. So this is a quick liberatory maneuver. This is the maneuver I personally favor because we get 2 rapid positionings. First, the patient is being taken to the dick-sulfide position, and second is the quick rotation. So there are the generation of it combines the inertial forces as well as gravity to move the clot out of the jammed area. So the third is the 45-degree force prolonged positioning to the contralateral, that is the non-inward side. So this is shown here. Otoconal debris is here, and it is believed with the force prolonged positioning of 8 hours, it goes back into the utricle. There are doubts about the success of 45 degrees force prolonged positioning. First is that 8 hours of 45 degrees FPPP is uncomfortable and possibly difficult. Second is that if there is a partial jam in the non-impulsionary arm close to the crus commune, how can gravity alone move the otoconia to the utricle? The third is practical advice is to execute either demi-Semont maneuver or quick liberatory rotation maneuver and instruct the patient 45-degree FPP for maximum tolerable duration overnight and review the patient coming morning. Or those patients who are not fit at all for the first 2 maneuvers, that is the demi-Semont and QLRM, they may be given this choice. This is the position in which you are supposed to lie during the FPP for 8 hours. So this is a case again which I had shown, on which I had done the QLRM earlier on, the video I had shown. It is the nystagmus oculomotor patterns before and after doing the maneuver which I already shown, QLRM. So the right dick sulfide test shows, just see the left eye, because right one, the setting of comfort foam is not there. You see a nystagmus which is clear cut down beating, and the upper poles of the eyes, there's the torsional component is directed towards the patient's right. The upper pole side of the eyes are beating towards the patient's right. So this is not very appreciable always. It is although appreciable here. That's why the successful execution of the QLRM was done in this patient. So this is before. We did 5 QLRM. The positional retests were performed after 1 hour. So in my practice, I do the repositioning maneuver or any physical therapy, and then I assess after 1 to 4 hours later. So after 1 hour, no nystagmus, patient is asymptomatic. But still I call the patient next day and record the oculomotor patterns during the positional testing. Elimination of nystagmus as well as positional vertigo is essential to ensure a cure. So this patient had a relief after 5 maneuvers. This is a case 3, which is an important definite grade. This, the earlier patient you had seen was the Caliphanos grade 2. This is that was the probable because it resolved directly. So this is the apogeotropic variant. I have combined this in one slide only. This is the left dexalpike test showing a downbeating left torsional nystagmus. Torsional component is very clear. The upper poles of the eyes are beating towards the patient's left. So we performed several maneuvers in this patient. Once he was given a demisemon, then QLRM, and then overnight FPP. Examined the patient next day. It converts into the right-sided typical posterior semicircular canal BPPV. So this is the most definite variant according to the Caliphanos classification. So again, I have to emphasize that the excitatory projections of the left anterior semicircular canal and the inhibitory projections of the right posterior semicircular canal are to the same group of muscles, right inferior oblique and left superior rectus, and therefore the slow phase VOR is upbeating and right torsional. The positional nystagmus, which is a fast phase VOR or a reflexive second, is downbeating and left torsional, whether it is apogeotropic right posterior semicircular canal BPPV or the left anterior semicircular canal BPPV. However, apogeotropic posterior semicircular canal BPPV is 6 times more common compared to anterior semicircular canal BPPV. Therefore, I treat peripheral positional downbeating nystagmus more commonly as apogeotropic posterior semicircular canal BPPV than anterior semicircular canal BPPV. This is case 4. This is my last case today. This is a biphasic nystagmus. This is the left dexalpike test. Here you see a downbeating left torsional nystagmus. Again, a slow nystagmus, slow crescendo decrescendo nystagmus, left torsional downbeating. So whenever you see a downbeating nystagmus during dexalpike test on one side, it is mandatory to do all the 3 tests. That is the dexalpike on the other side, as well as the straight annulled straight head hanging test. And the main focus should be on the identifying the torsional component. So this nystagmus is slow. Again, semiparoxysmal, looks like the apogeotropic variant, and if it is apogeotropic, it has to be on the left side because the torsional component is beating towards the. It has to be on right side because the torsional component is beating towards the left. So we performed a dexalpike test on the right side also, and now this is interesting. You'll see a upbeating nystagmus, which is very much crescendo decrescendo, typical variant of the right posterior semicircular canal BPPV. Then it slows down and then it reverses. While maintaining the right dexalpike position, now it is become downbeating and semiparoxysmal, that is slow crescendo decrescendo. That like the one which we saw on the left side, and the torsional component is again beating towards the left side. So what happened to this patient? Why biphasic nystagmus on the right dexalpike test? We recently reported this patient. This variant is reported earlier on only 4 to 5 times, but no one has elucidated the mechanism. So I did the left dexalpike first. The otoconia, which was in the non-ampullary portion of the right posterior semicircular canal, during the left dexalpike test, it moved away from the crus commune towards the the ampullary region. So as he got up, as he was uprighted from the left disc sulci position, it reached the periampullary position. And now, when subsequently the right disc sulci test was done, there was a biphasic movement. Why biphasic movement? The otoconal clot would move away from the ampulla, that is the cupula, right cupula, and it found a partial canal jam just in the near the cross commune, and it ricocheted back, and it then produced the inhibitory nystagmus. So that is the reason the inhibitory nystagmus, the biphasic nystagmus, was seen during the right disc sulci test. So Califano's classification of the epigeotropic posterior semicircular canal BPPV is the grade of classification is based on the response to treatment. The definite grade means implies to the intracannular transformation to typical posterior semicircular canal BPPV within 2 days of physical therapy. That happened in our penultimate case, the case I showed before the biphasic nystagmus case. That was the definite grade because it converted to the typical variant. The probable variant is when it resolves directly without transforming to the posterior semicircular canal BPPV after physical therapy. The case which I had shown, first case which I had shown. The possible when the symptoms persist despite 5 cycles of physical therapy or maneuvers and a normal MRI or patient is lost to follow-up despite ongoing symptoms. According to Califano, if the 5 maneuvers, whatever you choose, 5 cycles of physical therapy fail, then get a MRI done to rule out the MRI of the brain and CV junction also. And then you proceed for further treatment. So this is a possible grade only when it does not resolve after the 5 cycles of the treatment. Now comes the practical tips. They will not be found in any studies because no systematic studies are done. Neither the Baronese Society recognizes this variant. But you see it. Identifying the torsional component, often subtle, is pertinent to the diagnosis literalizing this disorder. Choose QLRM or demi-cement maneuver as per the patient's profile. Some patients may not be fit for QLRM, so they may be treated for by the demi-cement maneuver, or they may not be fit for either. Execute at least 5 times in one session, and then ask the patient to lie in the 45-degree FPP for 1 hour and then do a position retest. If still asymptomatic, repeat QLRM or demi-cement maneuver and follow up next day for positional retest. If still symptomatic, do blender of exercises in the morning and 45-degree FPP at the night for maximum possible duration every night with weekly follow-up. Initially, during enhanced hanging position, the hyperextend the neck for a minute and then complete the Yakovino maneuver. Immediately do a positional test. If no resolution, take it for granted that it is epigeotropic posterior semicircular canal BPPV for sure. The suggested readings are by 5 of these. One of my articles has 7 cases here. This is the 6th reading. But the most important one is by the Venuki. This is the 2005 paper from which I have taken most of the material. Future directions. 2 important things are feasibility of using video head impulse test to detect the inward canal in BPPV, presenting with positional downbeat nystagmus. They have found, the Andrea Castellucci, the Italian group, has found that overall V-hit sensitivity in detecting the affected semicircular canal was 72.9%, increasing to 88.6% when considering only cases with persistent positional downbeat nystagmus, where an incomplete canal plug is most likely to occur. That is the partial canal jam. This study is of 2020. However, our own Indian study from the South India, the Bangalore, by Razana Abdul Rahim, they say that V-hit shows low viewer gain in affected semicircular canals compared to the normal canals, and it is not statistically significant. We conclude that currently available equipment for V-hit, remember they did V-hit on Autometrics from Denmark, is not useful in diagnosing BPPV. However, further research on this is needed so that minute changes in view or gain can be recorded, which may aid in the diagnosis and management of BPPV. After reading this article, I found that they did not had any single case of apogeotropic variant in this study, which was published in August 2002. I finish by thanking you all for listening me.
Oh, thank you, Dr. Watts. I think this has been a brilliant talk. It has kept us challenged all the time, trying to keep pace with the vertigo. It's almost a vertiginous talk in its own right. But I now invite Dr. Rajiv to share some of his insights in this topic and maybe ask some questions from Dr. Watts before I throw the uh, topic open to the audience, and then I will put in some questions and some summing up. So, Dr. Rajiv, would you like to come in now?
Yes, sir. Thank you. Very excellent presentation by Dr. Watts. Very thought-provoking topic, and I'm sure that I have missed out some cases with this type of BPPV. But I do have a couple of questions. So classically, when we were attending various trainings earlier, we were told that patients exhibiting this sort of nystagmus on provocative maneuver for the posterior canal can be considered as cupulolithiasis. And even now, many of the textbooks do recommend for cupulolithiasis to do a CMOT maneuver, and they also suggest use of vibrator to dislodge the otoconia. So, what is may I ask Dr. Watts, what is his view regarding how to differentiate cupulolithiasis from this type of BPPV, and whether he has any experience using devices like a vibrator to dislodge it?
Very good question. The cupulolithiasis of the posterior semicircular canal, it can present with the upbeating ipsitorsional nystagmus, or it can present with the downbeating contratorsional nystagmus. It depends on how the cupula is angulated, whether it is a canal angulated cupula, whether it is a neutral cupula, or whether it is a vestibulum angulated cupula. So the prolonged duration, it is the persistent nystagmus, whether upbeating or downbeating, and depending on the angulation of the cannula of the posterior semicircular canal, it could be upbeating or downbeating. However, each posterior cupula has two potential provocative positions, which are 180 degrees to each other. So whenever you are suspecting, you are saying a prolonged duration nystagmus of more than 1 minute duration, you need to do an inversion test. Inversion test means that you do a opposite nose down test, opposite nose down position. Suppose the right Dixhall pike elicits a upbeating right torsional nystagmus of more than 1 minute duration. Do a nose down to the left lateral recumbent with nose down. If the nystagmus, which was upbeating and right torsional, becomes downbeating and left torsional during the nose down, it is a acid test for cupulolithiasis. So you need to know that cupulolithiasis will have this thing. Secondly, the cupulolithiasis will not respond to any of the maneuvers. The vibration with mastoid, whatever vibrator we use here, will not dislodge. I have tried in many patients. Recently, I had a patient. I had a series of patients with short arm posterior semicircular canal lithiasis with or without cupulolithiasis. And the patients with cupulolithiasis, I tried everything. I started from the mastoid oscillation with a vibrator. Then I did a very rapidly executed Schmidt's maneuver, and none of my patients they responded after giving fair number of trials. So most of those patients they respond within a period of 1 month, but how they respond they don't know. There are two studies from a Japanese worker, researcher on this, according to one of the study, most of these patients of pupillolithiasis, they respond within a period of the 1 month period. The second thing is that the the, the positional downbeat nystagmus of more than 1 minute duration can also occur in the anterior canal BPPV, but the pupillolithiasis of the anterior canal is not known to exist as per the Berenice recommendations or classification. So this is my take on the pupillolithiasis and persistent nystagmus.
Oh, thank you very much, sir. I think you cleared my doubt. The change in the direction on nose down would probably give a definitive diagnosis of cupulolithiasis. And of course, non-response to treatment. That would also probably be one of the indicators.
Great. So we have a question from the audience asking what is the duration between your liberatory maneuvers which you do?
The 1 and 2, 2 and 3, etc.
Yeah.
It depends on the tolerability of the patient. Normally, I do in succession. If I have to do the maneuver, I will do the one time, then I'll wait for 1 minute, and then I will do the second one.
Okay. No, but if you want to repeat this, you said on a daily basis, do you do it once a day, once in 24 hours, 48 hours? Do you have any particular...
No. In every patient of my BPPV, I see patients in 2 sessions. One in the morning from 9 to 1, and then other in 3 to 5. So if the patient comes in the morning session, I'll give him treatment, and then I will retest him in my evening OPD timings. If somebody comes in my evening OPD timings, I just do the repositioning maneuver or visual therapy, and I call him next day morning. So at least 3 follow-ups I do. One is around 1 to 4 hours later, and the other is 24 hours later.
So as a question, if I may ask, if you have followed up your cases over a duration of time, what is your general sense? I'm not asking for data, but your general sense of the chances of recurrence of patients who have autoconias which have once broken apart.
See, almost 40 to 50% of the people will have recurrence, and mostly the recurrences occur within first 6 to 12 months only. And many of these, they occur, most of them, they occur within 6 months only. And if they are occurring on the, if you say that you have a patient who was symptomatic on day 1, and it has another the next day you see it is still symptomatic, but the chances is that you have not properly treated him, or there is a canal switch. The canal switch has occurred. So that's why the 2 follow-ups after the maneuvers are important over a period of 24 hours to know what has happened, whether you have incompletely treated the patient or there is a canal switch.
So as part of your standard management, do you warn patients of the risk of recurrence?
Yeah, why not? I always say that 50%, there are about 50% of the patients will have recurrence over a period of 1 year. So I always warn them.
And there is another question on the chat asking about, just a minute, I think there was a question asking about the differential diagnosis of vestibular migraine creating a problem in your diagnosis.
Diagnosis of what? Vestibular migraine?
Yeah, because of the movement of the eye, downbeating nystagmus.
Most of the patients with vestibular migraine, they have normal oculomotor patterns. They can have they can have the nystagmus, positional nystagmus, because positional nystagmus is also reported to occur in patients with vestibular migraine, but that is non-fatiguing. and that will keep on during the position is at. So that will behave like cupulolithiasis, and it will not be specific to any canal. It can occur in right exalpine, it can occur in left exalpine, it can occur even during the upright testing. So that is not fatigable. It's not a problem. It is the duration of attacks which is more important.
So as the questions are now thrown open to the audience. If you would like to type in on the chat or even take the mic, we'd be happy to field them. Hello. If there are any questions. Otherwise, I come back to a general question. Um, in this classification of kinds of or causes of this BPPV, do you also have an American classification from the American Association which is different, or is it always the Bharani's which takes precedence?
This is a controversial question. You are trying to trap me
That's
into
why
that.
I asked. That's the moderator's preserve.
See, if you ask me about the classification from the American Academy of Otolaryngology, head, neck, and surgery, I would say that I would personally believe more in that compared to the Parani Society's classification. Because in one of the recent meetings in this month only, where I was chairing a session from a very great authority on Vertigo, I was just snubbed that you don't talk about apogeotropic variant because you are making confusing it like it. So those people are more involved in the Baranic society. I more believe in the the literature which was floated about 6 years back by the Bhattacharya et al. Of the American recommendations of the American Academy of Otolaryngology, Head, Neck, and Surgery.
So I think I don't know. Maybe this is choti muh badi baat, but I think considering the number of people who have demonstrated interest in Vertigo, we should move towards forming our own study groups and having our own classification based on our own experience.
Yeah,
Maybe
yeah, yeah.
four or five.
Sir, the Indian study which I showed that was from Mangalore only. I showed here because we have plenty of patients. We do not do any systemic studies, and our studies can be as robust or much robust than that published from the West. So that's why I show that the 2020 article of the Italian group was showing a significant advantage of V hit in diagnosing patient with positional downbeat dysdiagnosis, while none of the patient in the group of Mangalore, which published this in 2022, they found it. Although their study did not had any patients with apogeotropic variant, which is associated with the canal jam. So basically, canal paralysis will occur whenever there is a partial canal jam or a complete canal jam. So we need to do more studies on vertigo, every type of vertigo, not only BPP.
So we will be reaching out to you and to all the other members to try to create a movement in this direction, apolitical and academic.
Yeah.
I think there is one more question regarding cupulolithiasis, your method of dealing with that. I think I saw a question in the chat.
Sir, how are you treating cupulolithiasis BPPV?
Yeah.
I will say about the cupulolithiasis BPPV. First, number one, the horizontal cupulolithiasis of the horizontal semicircular canal is much more prevalent than the cupulolithiasis of the posterior semicircular canal. Number one. The cupulolithiasis of the horizontal semicircular canal is, I found that this has also undergone a change over a period of 5 years. 5 years back, I would go for head shaking maneuver. I would try to convert it into the geotropic variant or direct resolution. So direct resolution will occur if the otoconal debris is adherent to the uticular side of the cupula, horizontal cupula. It will fall back on the uticular macula and will get embedded, and there will be direct resolution. And if you do a brisk head shaking, then if it is on the canal side of the otoconal clot is adherent to the canal side of the cupula, horizontal cupula, it will convert into the geotropic variant. But over the past 1 year, I have found that the Zuma maneuver by the Professor Zuma Maya from Brazil is very useful in patients with horizontal semicircular lithosis, and it works very well. Only one of my patients didn't work. That was a chronic patient of 1 month duration. And in fact, recently I had one paper in which I added one more position to the Zuma, which I have named as Zuma plus maneuver. I will share on the group once it is published in records. It is already published online. This is about the cupulolithiasis of the posterior horizontal semicircular canal. The cupulolithiasis of the posterior semicircular canal, I don't have any answer. Nobody has any answer. The mastoid oscillation, which Dr. Rajiv was talking about, did not work in any of my patients. I have seen more than 15 to 20 patients with the posterior semicircular cupulolithiasis over past 2 years, but none of them did work. Fast remount, it doesn't work. Rapidly action, but one of my colleague from Bhilwara, she told that it worked for her patient. So first thing is that the Dix halpike or the half halpike test which we do for the cupulolithiasis of the posterior semicircular canal has to be followed by an inversion test, that is nose down to the opposite side. Then and then you can say that this the persistent nystagmus which occurs during the half halpike position and the is because of the cupulolithiasis. If there are otoconial debris on the short arm of the posterior semicircular canal, during the half alpine position, they will fall upon on the uticular side of the cupula, and in the half alpine position, they will again elicit the nystagmus, which will be of more than 1 minute duration. But on nose down to the opposite side, the debris in the short arm will fall away from the uticular side of the cupula, and there will be a negative inversion test. So whenever you do a half alpine testing for the cupulolithiasis, always do a inversion test, and if the inversion test is negative, there is no nystagmus during the inversion position, is likely to be the short arm posterior semicircular cannulolithiasis.
Okay, so I think we've had a really very satisfying discussion. To sum up, Dr. Watts has presented his experience with apogeotropic semicircular BPPV of the semicircular canals, with some take homes for all of us. Number one, I think we should get back to our textbooks and get back to our orientation. Number two, we should remember that all the tests should be repeated until we are certain that we have cured the patient. Number four, that we should call the patient for follow-up, maybe after a week, and warn them that there is a chance of recurrence. Number five, that there is need for documentation, there is need for comparison, there is need for studies. And like you get newer and newer forms of BPPV being discovered even in the 2020s, who knows, we may be discovering more and more things if we do a very systematic study. I thank Dr. Watts and Dr. Rajiv, and I look forward to Dr. Watts conducting many more such programs. And I invite everybody who has attended to start sharing their cases, because it is only by sharing that you get to know who else is interested in this topic and how we can grow further. As long as we keep politics out of it and stay wedded to academics, I think India has a great future. Thank you all very much. I think, Dr. Watts, I thank you again. Dr. Rajiv, I thank you again. And I thank all who have participated. Thank you very much.
Thank you. Bye.
Thank you, sir.
Bye.
Bye. Bye, Rajiv.
Bye, sir.
Thank you very much for nice presentation.
Thank you.